Malyugin Ring is my preferred device to expand a small pupil. So let's take a look at this case. This patient has had recurrent episodes of uveitis because of tuberculosis and now has a small 4 mm pupil. So after staining the anterior capsule and making the paracentesis as well as main incisions, the first thing we try to do is to remove this cyclitic membrane, but we can see that it is very adherent, and at this point I decide not to cause excessive trauma to the pupil, inject a dispersive OVD under the iris, just under the iris, to lift it up a little bit so that we can easily insert the Malyugin ring. And then the first scroll goes in, that should be our target, and we should also try to aim that we get another scroll in. So this is what we need. We need at least 2 scrolls in as soon as we are implanting the Malyugin ring in the anterior chamber. And now with the help of a dumbbell dialer and an iris repositor, we have secured all the 4 scrolls, and we can see that we have an adequate sized pupil. The next step here is to perform a capsulorhexis. Sometimes if the pupil is small and we feel that the cataract is hard, we do not have adequate staining, we can stain again before we begin the rhexis after removing the OVD from the anterior chamber. In this case, the anterior capsule is well stained, so we go ahead with our capsulorhexis, which is completed with the help of cystitome. We have a decent size rhexis, and this is another advantage of using Malyugin ring. The rhexis size becomes adequate. If we try to do the same surgery without a pupil expansion device, we land up in a small rhexis as well. And then after hydrodissection, hydrodelineation, we place some OVD before we go ahead with our phacoemulsification. And my preferred technique, especially if we want to be as safe as possible in cases like these, is using a stop and chop. So here we go ahead with creating a trench and then splitting the nucleus into 2. We can see that this patient has a significant posterior subcapsular cataract. So we go ahead with our chopping maneuvers. The cataract is not too hard, just a grade 2 cataract, and we are able to emulsify this with ease. We just have to be careful about the endothelium here. There can be some pigment dispersion as well because of the ring and because of the past uveitis. So we need to coat the endothelium with a good dispersive OVD which has chondroitin sulfate, and try not to be too anterior when we are performing the phacoemulsification. And now when most of the nucleus is out, we remove the epinuclear plate and this thick PSC that we can see. And before we come out, I'm just injecting some dispersive OVD from the paracentesis to avoid chamber collapse. We go ahead with a bimanual irrigation aspiration to clear off the cortex that is remaining, always making sure that we are looking at the rhexis margin and at the position of the ring. And we can see how good the visualization is. Sometimes if we try not to do it with any pupillary expansion device, even if we are able to complete phacoemulsification, the irrigation aspiration becomes really tricky. So here all of the cortex is aspirated with bimanual irrigation aspiration. And now the step here is to place IOL in the bag. So after cleaning up the anterior rhexis margin, this is the IOL that goes in. This is a single piece IOL, Eyehance by J&J. In these cases, we avoid trifocal IOLs especially, but EDOF IOLs can still be implanted if the retina seems alright. This patient had no macular edema, no ARM in the retina. And now we remove this Malyugin ring. We remove all of the scrolls first, and then using the same device, we take out the Malyugin ring. We can wash it thoroughly with BSS and place it again inside the injector. These can be reused after ETO, and they do work at least once more. So we can keep them for patients who cannot afford this ring. So we place it inside and just send it for ETO. Now the remaining OVD is removed from the anterior chamber thoroughly, and we can see that the pupil has not had any sphincter tears or any damage, placing an air bubble before we end the case and seal the incisions. Thank you.